do they come up with these codes? Molly, the other. Another.
Just start.
Right.
Hello, everyone.
Hey.
Everybody hear me okay? Good. All right. So I'm Dr. Hum. I'm going to do a lecture on spasticity. I'm going to go over the basics of spasticity. So it's going to have some detail, but not extreme detail. I'm part of the Physical Medicine Rehabilitation Department, mostly based out of Health Plaza A. I have no disclosures. Goals of this lecture, I'm going to define spasticity and its etiology, describe the affected populations, review the evaluation of patients with spasticity, determine when treatment is needed, and explore the treatment options. We're going to go over some definitions just to get some baseline information on different muscle terms that you might hear during this lecture, you might have heard already. So muscle tone is resistance of a muscle to stretch or passive elongation. Hypertonia is the subjective description of tone being greater than normal. Spasticity, which our lecture is on, is a velocity-dependent increase in muscle tone. Rigidity is resistance to stretch that is not velocity-dependent. Dystonia is muscle contraction causing twisting, turning, and posturing. We see this with like spasmodic torticollis in the neck area in babies and adults. And then clonus is involuntary rhythmic muscle contraction or spasms, and we usually see this in the ankle, plantar flexor of the foot, throbs up and down. So spasticity is, most cases, is due to an upper motor neuron lesion causing an increase in tonic stretch reflexes. This results in intermittent or sustained involuntary activation of muscles, resulting in increased muscle tone, muscle stretch reflexes, clonus, and the reemergence of primitive reflexes. This slide is going into much more deeper into the physiology, but in general, the true mechanism of spasticity is not completely clear, and it varies depending on the type of injury that leads to spasticity. There is usually a loss of inhibitory control by the descending pyramidal and reticular spinal tracts, maladaptive branching of the residual cortical spinal and reticular spinal tracts, hyperexcitability of the reticular spinal, vestibular spinal, and cerebrospinal projections, which then all leads to increased sensitivity of the stretch activated muscle spindles, which then results in spasticity. I don't expect anybody to remember that, but that's the background. So as far as who gets spasticity, we're going to talk about the demographics. About 35% of patients that have a stroke will get spasticity, 40% of traumatic brain injuries. We see spasticity in neoplasms. I was unable to find a percentage though. About 90% of kids and adults with cerebral palsy, 37 to 78% of people with multiple sclerosis, and 40% with spinal cord injuries. There are a lot of other diagnoses that can also get spasticity, especially the group of diagnoses that are under hereditary spastic paraplegias. I think there's like 80 plus different diagnoses that fall underneath that. And a lot of those usually affect the legs and calves. And I've done Botox and botulinum toxin injections and other medications to treat some of those patients in the past. So when you have spasticity, acutely, what we see with somebody who develops spasticity is the affected trunk and limb muscles are usually flaccid, meaning no strength. And we have loss of reflexes. Subacutely, which occurs anywhere between 1 and 4 weeks usually, and sometimes longer, we see the reflexes come back and they become brisk and more exaggerated. We see increased muscle tone and spasticity occurs in the affected muscle groups. And then chronically with spasticity, we see muscle contractures, meaning loss of range of motion, bony deformities such as tibial torsion or hip dysplasia in children with CP, or postural and functional abnormalities. With spasticity, we see a lot of different positive and negative findings. So we see increased tendon reflexes, clonus, Babinski reflexes, extensor spasms, meaning the whole body will spasm into extension, or flexor spasms when they're curled up. We see mass reflex, that's more in spinal cord injury patients, and mass reflex is an old term for autonomic dysreflexia. But if a spinal cord patient has tight clothing or urinary tract infection or urinary retention, they might go into spasms as part of the autonomic dysreflexia cascade. We see dyssynergetic synergistic patterns of co-contraction during movement, associated reactions, and other dyssynergetic and stereotypical spastic dystonias as well. Negatively, we see muscle weakness, loss of dexterity, and easy fatigability, especially with prolonged walking, moving, and any prolonged movements in general. So when I see somebody with spasticity, as all patients, we get a history. I specifically want to know about the mechanism of their injury. Was it a stroke, brain injury? Where did it occur? And how long ago it was. I also want to know what parts of the body that the injury affected. Was it just the arms or the legs, one arm, both arms, and so on. I want to know if they have any pain, especially related to their spasticity. I want to know if they have any spasms.
Hey, thanks a lot. How are you?
Sure, what's up?
So this lady, that's why she came to us.
Okay. I want to know about their strength and how their strength has changed since their injury. So initially, again, a lot of people after a stroke or brain injury, they might have significant weakness. I want to know if they've progressed in strength and what is progressing, what's not progressing. I want to know what triggers their spasticity. I also want to know about the current function. Are they currently ambulating? And if they are they using a walker, cane, wheelchair? How are they getting around? How they're doing transfers? And if they're able to do their activities of daily living, and how the spasticity affects all these activities for the patient. I also look at their hygiene, safety, and the caregivers themselves. So in hygiene, I want to know, like, are they having skin breakdown because their hands clenched all the time and you can't clean it between their fingers and it gets moist and it causes skin breakdown or anything like that? Or if they have that in the armpit because their arm is so tight they can't move it, they can't abduct it away from their thorax. Looking at caregivers, I want to know, are the caregivers struggling changing the patient clothes in the morning and at nighttime when they're changing back to nighttime clothes, or changing their diapers if they're incontinent, or however else the caregivers are being impaired by the spasticity. I want to know about their previous and current treatments, including therapy, medications, and injections. And I want to know about the goals of the patient. And this includes short-term and long-term goals. So I want to know if the spasticity is specifically affecting their ability to walk, how we can improve that short-term. But I also want to know what the long-term expectations and outcome of the patient is going to be. Are they at a facility? Are they at home? Are they going to stay at home? Are they going to go home eventually? And then also what their home situation is going to be like if they are going to go home. Do they have steps to navigate to get in or inside the house? Do they have a single level with a bathroom, bedroom, and kitchen? Or are they going to have to do a lot of navigating? Because that all affects our ability to treat their spasticity. We might say, we want this muscle to stay more spastic to help them function better. So when I do a physical examination, I'm going to look at passive and active range of motion of the affected and unaffected limbs, look at strength testing, reflexes. I'll do a spasticity evaluation, which I'll talk about in more detail in a second. Look at their gait, and particularly looking at their gait, I want to know if they're swinging their leg out wider, or if they're catching their foot on the ground because they have plantar flexion deviation and they're catching their toes. I also want to look and see if they have any functional movements that might be useful. So if somebody has upper extremity spasticity, I want to know if they can bring their arm towards their mouth and feed themselves, because that's a really important independent function that a lot of patients would like to gain back if they don't have it. So when I'm looking at spasticity, when I evaluate somebody for spasticity, as I said, it's a velocity-dependent increase in tone. So first off, I'm going to do an example of the arm. So if the arm, elbow flexors are spastic, I'm going to do range of motion of the arm first to find out what type of range of motion they have. And then when I actually test it for spasticity, I'm going to do a quick jerk or quick range of motion on the arm to see if I see an increase in muscle tone, either a catch and a release or a catch and increased tone going forward. And that's spasticity. So when we look at spasticity, we use a couple different scales to relay this information to other colleagues. And one of the scales that's most commonly used is the modified Ashworth scale. And this is what I use in my clinic. It's a 0 to 4 scale, but then there's also a 1+ in it, which just throws us all off. A 0 means no increase in tone. A 1 means a slight increase in tone, manifested by a catch and a release or minimal resistance at the end range of motion. A 1+ is a slight increase in muscle tone manifested by a catch followed by a minimal resistance throughout the remainder or less than half of the range of motion. A 2 is more marked increased muscle tone throughout most of the range of motion. A 3 is considerable increase in muscle tone. And also you might see tone with just slow passive movements as well. And then the 4 is it's rigid and it's stuck in flexion or extension and it's going towards a contraction, or it might already be in a contraction. There's another scale that some people use called the Tardot scale. This one is more used for research as far as as far as I've seen. And this one, they do a lot more marking down of what their tone is in V1, which is as slow as possible movement, V2 against gravity, and with gravity speed, and then V3 as fast as possible. And then the responses are pretty similar to the Ashworth scale. So when I see somebody's spasticity, we see certain positions that are very common. We often see a flexion position where the arm is adducted at the shoulder, the elbow is flexed, the forearm is pronated, wrist is flexed, and the fingers are flexed, and the thumb is flexed. And you can see some of those in these pictures here. And the lower legs, we often see the hips adducted together, the knees flexed. Sometimes we also see the knee extended. We see plantar flexion of the ankle, equinal varus deformities, as well as toe hyperextension and flexion as well. So when do we treat somebody for spasticity? Well, when it starts interfering with their function, we want to start treatment. And if it causes significant discomfort or pain, interferes with hygiene or nursing care, which we talked a little bit about already. If there's contractures or disfigurement occurring. Spasticity also increases the risk of decubitus ulcers at times. It may cause bone fractures, and if a fracture is present, it can lead to malunion due to the significant tone preventing the bone from being together or connecting with the other part of the bone. We see joint subluxations and dislocations. This is mostly in the hips and the shoulders, especially, I've seen this especially in stroke patients in the shoulders where their shoulder is just subluxed and it causes lots of pain. We can see, with spasticity, we see increased risk of heterotropic ossification. This is the body's response to usually spinal cord injuries and traumatic brain injuries and spastic muscles, which leads to increased bone production, often in the hip area. We can also see acquired peripheral and entrapment neuropathies. So when considering treatment, I always consider the patient, but also I want to look at the family and caregivers as well as the therapist and how they're doing in therapy. So I try to talk to the family and caregivers and find out what they're seeing at home and what activities the patient's especially struggling with. Are they struggling with putting on and off clothes because their muscles are so tight they can't get their arm through the openings in a t-shirt? Or if they're incontinent, if they're in diapers, is it hard to change a diaper because their hips are adducted so much that you can't spread their legs apart and clean them adequately? I talk to the therapists because they're actively helping the patient gain more function, but spasticity can impair that function, and it might be impairing their ability to progress in therapy with either ambulation or transfers. I also want to look at, when I look at treatment options, I want to know if it's going to be a systemic treatment or more of a focal treatment. And then the overall goal of treating spasticity is to reduce maladaptive abnormal tone while improving function. There are some benefits of tone, though. So tone may improve ambulation, standing, and transfers, especially stand pivot transfers. So if somebody has weakness in their right leg and they have weakness especially with their quads and they can't extend their leg very easily, but they have spasticity there where it makes their leg go straight, they have an easier time standing because that muscle is spastic and it helps them do that stand pivot transfer. Spasticity also helps maintain muscle bulk. It can help prevent DVTs by improving venous flow, prevent osteoporosis, decrease the risk of pressure ulcers, especially over bony prominences, and this is mostly due to the muscle bulk being maintained. It can help identify noxious stimuli if present. So in some people, especially brain injury, strokes, and spinal cord injuries, if they have an infection, bowel impaction, urinary retention, they get more spastic. So that's an indicator that something else might be going on. We're going to move into treatment options. So the first treatment option is the best treatment option is to avoid noxious stimuli if present. One of the early things for most people with any spasticity developing is to start them in physical therapy and or occupational therapy to get them moving. And this includes stretching and range of motion, splints, serocasting modalities. We also look at systemic medications that can help spasticity, local interventions or injections, and surgical procedures. So therapy, again, initiation of therapy early on after a central nervous system injury is important for recovery. One of the first things that they start doing is they work on range of motion and stretching because we want to prevent contractures and muscle tightness. And this can be active by the patient, staff, or family, or it can be passive with the use of splints or serocasting. So active range of motion that we often teach people in the hospital or even in clinic or in outpatient setting is if they have tightness of, let's say, their finger flexors, you might have them extend their arm and pull their fingers back with their other hand to stretch their finger flexors. And if you have a patient that's not capable of doing that on their own, you want to educate the family because, again, you want them to do the stretching consistently. Passive types of stretching would be like using a wrist splint, where somebody has, again, tight finger flexors. They've had their hand in a resting wrist splint, keeps their wrist at neutral position and fingers in more of a neutral position. And we usually utilize that at nighttime and throughout the day to help prevent them from having fisting of the wrist and flexion of the wrist and fisting of their fingers. Serocasting, this is something that I've only seen in the pediatric population, most of cerebral palsy. If a child has a plantar flexion deviation of their ankles and they're a toe walker and you want to get them back into dorsiflexion, you can do some treatment options, which I'll talk about in a little bit, like botulinum toxin injections or chemoneurolysis, and decrease that spasticity. And then they will get a cast every week that eventually puts them into more dorsiflexion gradually over time. And that will break that habit of plantar flexion and improve their ability to do heel striking when walking and improve their gait. Cold modalities can decrease muscle spindle reactivity and help with stretching and spasticity. Hydrotherapy is helpful. Functional electrical stimulation, especially when performing functional activities, is helpful. And I have my next slide will go over this a little bit more detail. Strengthening of the opposing muscles. So if somebody has really tight elbow flexors and they're always in flexion, you want to try to strengthen their triceps and elbow extensors because that's going to fight against the spasticity in the elbow flexors. Vibration, biofeedback, and direct tendon pressure can also be helpful. So functional E-stim, I have two pictures here. The one on the left is a patient that's likely in therapy. They have some stimulators placed on different parts of their body. In particular, you can see the one on the forearm, back of the forearm, and that'd be triggering the finger extensors and wrist extensors. And this would allow the patient to open their hand to grasp an object, and then their spasticity in their hand would allow them to hold on to the object and move it. And that's just working on functional motions. On the right side, we see a picture of a person walking, and they have an electrical stimulation device on their lower leg. And in this case, this device would send an impulse to the tibialis anterior, which would cause dorsiflexion on the ankle, and it could help them walk without catching their foot on the ground due to plantar flexion spasticity. Multiple companies make devices like that, and this is just one of them. They also have devices for functional E-stim for the arms to cause finger extension. Medications. So medications is one of the early steps in treating spasticity. The good and bad at times is that they often cause systemic effects. And due to this, they're most helpful in spinal cord injury and MS patients. They are known to reduce tone and pain, but they have questionable evidence for improving overall function. I think that's more thinking about medications alone, because function really improves with doing therapy, stretching, and everything else to improve function. So a couple medications we're going to talk about is baclofen, clonidine, dantrolene, diazepam, and clonazepam, and tizanidine. So baclofen, mechanism of action, it acts on GABA agonists at GABA B receptors, increasing inhibition of monosynaptic and polysynaptic spinal reflexes. It also may affect substance P in the spinal cord and help decrease in pain. Major thing to think about if you're giving somebody baclofen is that it's sedating. And it also lowers the seizure threshold. So if you have somebody with a traumatic brain injury or stroke, and they have a history of seizures, you might want to give them baclofen because they might get more seizures. So things you need to consider, especially in the inpatient setting. Other thing with, oh, that was backwards. Another thing with baclofen is it mostly helps the lower extremity. It does help the upper extremity some, but it's more focused on the lower extremity for whatever reason. And then with baclofen, you want to be cautious of withdrawal. So most people start baclofen between 5 and 10 milligrams, and they get up to 10 milligrams 3 times a day, if not higher doses. And you can't stop from that dose because then you go through withdrawal. And that will result in agitation, insomnia, seizures, hallucinations, increased spasticity, and fevers. And the treatment for that is to get them back on baclofen and slowly decrease them off the baclofen and wean them off. Clonidine, I think most of us know what clonidine is. It's a central acting alpha-2 adrenergic agonist. In the spinal cord, it provides presynaptic inhibition of sensory afferents. It's mostly used in the spinal cord population for spasticity. Major side effect is hypotension and syncope and sedation. This can also cause withdrawal if removed very quickly. Dantrolene, this is one of the other most common medications used for spasticity in most populations. And actually, it's more helpful in most populations. This one actually works on the muscles by blocking release of calcium from the sarcoplasmic reticulum, decreasing muscle fiber contraction, strength, and muscle spindle sensitivity. It has minimal effect on cardiac and smooth muscle. It is especially used in patients with cerebral causes of spasticity, such as stroke, TBIs, and CP, because it's not as sedating as all the other medications. It's also more helpful usually for upper extremity spasticity than baclofen. So that's an extra added bonus to it. It can also be used for malignant hypothermia, which I don't treat, but it's another random fact. Big issue with dantrolene is it's liver toxic, and you need to monitor the liver function test if you're giving this. And I would say in probably 30 to 40% of people I've given dantrolene to, it does affect their liver, and I end up stopping it because it affects the liver. Insurances are also somewhat more difficult to get to approve dantrolene than baclofen. So usually I try baclofen first and then go to dantrolene. Benzodiazepines. Diazepam and clonazepam are the ones we most commonly use. Mechanism of action, they are facilitating GABA's effects on GABA A receptors subtype, causing membrane hyperpolarization and decreased neural firing. Most useful in spinal cord injury and MS patients because, again, they are sedating. Can cause CNS depression, they have a long half-life, and again, they can cause withdrawal. Tizanidine, which is a common muscle relaxer that a lot of us use in our practices. This one works centrally on alpha-2 adrenergic agonists. It's kind of similar to clonidine. It binds alpha-2 receptors spinally and supraspinally. This is used in spinal cord injuries, MS patients, and acquired brain injury as well. And trials have shown that it's just as effective as baclofen or diazepam with better tolerability. Again, another side effect of this is sedation. And it can also affect the liver, so you have to monitor LFTs. Other substances that have been used are cannabinoids, which may improve spasticity without decreasing power. These can cause sedation, hypotension, and mood disorders. I've only seen this used in the spinal cord population myself. Gabapentin can help with pain and spasticity as well, and there's lots of other medications that can be used, but they're less commonly used. Local interventions. So we can do diagnostic nerve blocks, chemical neurolysis, and chemodenervation. These local interventions are the best way to treat focal and local spasticity because it's not going to have a systemic effect usually on the whole body. So diagnostic nerve blocks, these are local anesthetic injections around the nerve. Usually when doing these, we will use electrostimulation or ultrasound guidance. And these blocks may last for hours. They're helpful for planning chemoneurolysis, which I'll talk about in a few slides. It can help with planning for botulinum toxin injections and for surgery. So 2 anesthetics that we use for this is lidocaine, which is a local anesthetic, and we use concentrations of 1 to 2%, and this lasts 1 to 3 hours. We also use bupivacaine, in concentrations of 0.25 to 0.5%, and this lasts 6 to 8 hours. Hemoneurolysis. This is done to cause a block in the spasticity that may last months to years. And we do this by causing demyelination and axonal destruction via protein denaturation and axonal necrosis. When doing this, because of the harm it can cause, you definitely want to use electrostimulation, EMG guidance, and ultrasound guidance usually. So a couple agents that we use for this are phenol in concentrations of 5% or greater in order to cause denervation, and you can use up to 20 to 30 milliliters max without causing, and doses higher than that cause more systemic effects and can be detrimental to the patient. Typically, phenol injections last 6 months. They are less painful than alcohol because they do have an anesthetic effect to them. Ethyl alcohol in concentrations between 45 and 100% can also be used. This is less toxic than phenol, and it may last longer than phenol. Complications of doing these injections. If you're doing an injection around a mixed nerve, meaning it has sensory and motor components, then you can cause dysesthesias, which are painful sensations along the nerve, and that is uncomfortable and can last weeks to months, if not forever. You can get muscle pain and tenderness, muscle weakness that may even be permanent. You can get transient swelling, increased risk of DVTs due to motor activity relaxation or decreased motor activity, sprains, and skin slough. And skin slough is seen in with phenol usually, meaning the dead skin occurs at the site of injection. Phenol can also cause systemic reactions if injected intravascularly, causing convulsions, CNS depression, and cardiovascular collapse. So, I personally have only seen phenol and alcohol used a few times, and that's in the pediatric population, usually in CP kids. You can also use it in spinal cord injured patients. In the upper extremity, you can do it for the pectoral nerve and thoracodorsal nerve, which will help with spasticity in the shoulder adductors and internal rotators. You can also do it for the muscocutaneous nerve, which innervates all the bicep muscles, so that can help prevent spasticity in the elbow flexors. In the lower extremity, you can do it in the operator nerve to help with hip adduction spasticity, the tibial motor branch for plantar flexors to help with plantar flexion, and this is usually what they use when they are going to do serial casting in a child with plantar flexion deviation. They do chemoneurolysis beforehand because it's going to last several months as they do their serial casting. And you can also do the sacral motor branch for the hamstring. Hemodeinnervation with botulinum toxin. So I'm going to spend a little bit more time on this because this is something I do offer in my clinic, and unfortunately I don't use the chemoneurolysis in the clinic because I don't have that population. So botulinum toxin is from the Clostridium botulinum bacteria. This is a bacteria that's in soil and water. Back in the day, they used to always say if you have a can that's bulging out that it might have bacteria in it. That's Clostridium botulinum bacteria. So smart people took this bacteria and fine-tuned it and turned it into injectables. So there's multiple classes of botulinum toxins. The two that we use in the US are mostly type A and type B. Type A has 3 different types of medications in it. First one is on botulinum toxin A, and I think this is one of the first ones that they developed. This is also known as Botox. Incobotulinum toxin A, known as Xeomin, and abobotulinum toxin A, known as Dysport. All of these have been approved by the FDA for adult and pediatric upper and lower extremity spasticity, and they are also used in lots of other things such as cervical dystonia, urinary retention, blepharospasms, sialorrhea, which is drooling. The only type B botulinum toxin in the US is rim botulinum toxin B, known as Myoblock, and this is mostly used for cervical dystonia and chronic sialorrhea. So I have seen or used all these at some point in my practice, most of them during residency. I trained down in Milwaukee with John McGuire, who's kind of a spasticity guru in the pulmonary department. And we've used Rima botulinum toxin B mostly for sialorrhea, drooling for kids with CP and other diagnoses, usually for excessive drooling. All the rest I've used for spasticity in the upper extremity and lower extremities. The one I use the most is onabotulinumtoxin A, and that's just because I'm the most familiar with it, and I've used it the most, so that's why that's my preference. But there's benefits of all the other ones as well, because some of them come in different vial sizes, meaning onabotulinumtoxin A comes in 100 unit to 200 unit vials usually, and if I only need 50 units, then I have to waste 50 units of the onabotulinumtoxin. So then I think Synvisc or Dysport, I forget which, Dysport or Xeomin, one of them comes in just 50 units, and so it's half the amount, which is nice. So, mechanism of action of botulinum toxins, they affect the neuromuscular junction where they produce denervation by blocking presynaptic release of acetylcholine. Acetylcholine then triggers muscle contraction, so if we're blocking this, the muscle can't contract. Type A botulinum toxins cleave SNAP25, and type B cleave synaptobrevin. And here's a picture of the neuromuscular junction, and the little yellow, let's see, I do this up, yep. Okay, so SNAP25 is here, and the synaptobrevin is over here, and so if you block that, the acetylcholine can't be released across the neuromuscular junction, and therefore you can't have muscle contractions. So when using botulinum toxin, this causes a temporary muscle weakness. It usually takes 24 to 72 hours to take effect, but can take up to 7 days as well, or longer, sometimes 10 days. Peak effect occurs between 4 and 6 weeks, and it may last between 2 and 6 months. Dosing frequency is every 3 months or longer. Side effects and caution. This causes muscle weakness, which we know that's why we're using it, but then also that can be harmful if you do too much into an area and cause excessive weakness. It can cause hematomas and bruising, and then flu-like syndromes as well. With botulinum toxin, you can see distance spread occasionally, and this can lead to dysphagia, so difficulty eating, or respiratory depression. This I have only seen in a few patients, and usually if you're doing a lot of botulinum toxin in the cervical region. Botulinum toxin is contraindicated in patients with Hashimoto's thyroiditis. And another thing to know about botulinum toxin is you can get immunity to it. And this usually occurs if you're doing high doses or if you're doing short intervals. And that's why we go every 3 months, because going 1 month to 2 months may lead to increased immunity, and then you've lost that mode of treatment. For administration of botulinum toxins, we often use EMG guidance, electrical stimulation, or ultrasound guidance. It's dose dependent. Therefore, if you give a larger dose of botulinum toxin into a muscle, you see greater clinical weakness. And if you are using one type of botulinum toxin and decide to switch to another one, there is no clear conversion between the two types of botulinum toxins. For guidance, I just put a couple machines up here. On the left side, that's an EMG machine that we use for nerve conduction EMG studies. As you can see, it's pretty large, and that would be maybe not the best tool to use for somebody who is getting botulinum toxins all over their body, because you'd have to move the arm of it to be closer to the patient to do injections at each location. So there's lots of other devices that are handheld, and that's what you see on the right side. And this is a device that I use in clinic. And I like this device because it has EMG and electrostimulation capabilities. So when using these devices, when you do a botulinum toxin injection, you go into the muscle. So if I'm doing for elbow flexors, I'm going to go into the bicep brachialis, and I'm going to go into the muscle, but I want to go to the motor point where you see the most activity on EMG. And so I can use the EMG guidance to help me guide me to the most active region, because that's where the botulinum toxin is going to have the best effects. And that works great for large muscles. But if I want to go, let's say, into a thumb flexor muscle, the the flexor pollicis longus, and I go into the middle of the forearm where the flexor pollicis muscle is, well, there's lots of other muscles in the forearm, and they're all close together, and they're all small muscles. I will not know for sure if I'm in the muscle or not. And if they have spasticity throughout their arm, it might all be making noise on EMG. So if I use electrostimulation, I can send an electrical impulse to the needle tip, and it'll cause that muscle to fire, and you'll see flexion of the flexor pollicis longus, so then I know I'm in the correct muscle. And therefore, I like the device on the right side because it has both functions. Surgical procedures. There's intrathecal treatments and then surgery treatments. Intrathecal backflow pumps, or ITB pumps. This allows direct delivery of baclofen into the cerebrospinal fluid where it takes its effects. And this allows a higher concentration reaching the spinal cord without causing as much CNS effects as oral baclofen does. And essentially, it's 100 times stronger if you go directly into the spinal cord versus taking oral baclofen where it has to cross the brain-blood barrier and so on. So the pump is a surgically placed device that is battery powered and programmable, and it has a reservoir where you can put your medication. And then it has a catheter that's flexible silicone that inserts into the intrathecal space. This is a diagram of somebody with a intrathecal baclofen pump. And usually the pump is going to be placed in the lower abdomen area. And if you look at the pump in the middle of it, you can see the little round circle, and that's the reservoir where the medication goes. And you can fill that medication through the skin by using a guide, putting it over there, and it has an opening in the middle where you put the needle, clean it off, put the needle through, drain the old medication, put new medication in. It's essentially the same pump that they use for pain management, so chronic pain management. The catheter placement, the catheter can be placed anywhere in the spine, and you place it depending on where you want to treat the spasticity. So if the patient has just lower extremity spasticity, you'd put it more in the lumbar spine. If they have upper and lower extremity, you'd go more in the cervical area. When using a pump, you can change the dosage transdermally with a computerized programmer. And with any of these pumps, they continuously provide a slow amount of continuous medication into the spinal cord or into the intrathecal space. And then you can also make changes in the program and do scheduled boluses or at timed intervals, which can be helpful for those patients. So if you have let's say a spinal cord injury patient who has lots of spasticity in their arms and legs, and every morning they're going to get up at 6:30, you can give them a bolus at 6:15 or so. That way, by the time they are ready to get ready for the day and change their clothes and do their bowel program or whatever else they need to do in the morning, that they're not as spastic and their muscles are more relaxed, which allows the patient to tolerate positions better, and that also helps decrease caregiver burden. Again, you can do refills to that port, and battery life is 5 to 7 years. This is mostly used in patients with diffuse spasticity, or if the patient has, especially those who have failed oral agents and or injections. Prior to doing an implantation of a pump, you do a test trial, and you can either do a single bolus of baclofen or continuous infusion through a percutaneous catheter into the fecal space, and then you measure them and see how their spasticity improves over the next few hours. If you're going to do a pump in somebody, you have to make sure you're doing close monitoring, and therefore you need a patient that's going to be very reliable and or their family is going to be reliable. And this is because it has lots of potential risk if you don't get reliable ongoing treatment. And the big thing is if the patient doesn't follow up for refills, then they're going to be out of medication, they're going to go into withdrawal. And that can lead to, again, increased spasticity, stiffness, fever, nausea, dizziness, hypothermia, itching, insomnia, hallucinations, and seizures. Occasionally, the pumps can also have malfunctions, and that can lead to overdosage, which can lead to hypotonia and weakness, among other sedation and bradycardia and other symptoms. You can also put some different medications into the pumps. Like I said, they're used for pain pumps as well. So you can use morphine, which may help with chronic pain and spasticity, and midazolam, which can help with spasticity as well. Surgical procedures are used to target specific areas. These are often irreversible and require significant pre-procedural planning. And the pre-procedural planning often involves the diagnostic nerve blocks, botulinum toxin injections, so you can help plan with what you need to do surgically as well as what your expected results might be. So some of the surgical things you can do Achilles tendon lengthening, which is usually a Z-plasty. You kind of make 2 cuts in the Achilles tendon at opposite sides at different levels, and it allows you to stretch the Achilles tendon further. I'm simplifying that a lot, I'm sure. You can do a tenotomy by cutting tendons, and this is often done for the hamstrings and iliopsoas tendons. You can do myotomy and cut muscle fibers to release the muscle, and this is often done for adductors to release the adductor muscles when you have hip dislocation due to spasticity. You can also do tendon transfers. And a tendon transfer involves taking a tendon that is functional and moving it to improve function in a region of the body that muscle is no longer functioning, or other side effects are causing, such as spasticity, causing abnormal positions. So with equinal varus, where the foot is pointed and rotated, you can do a split anterior tibial tendon transfer. Essentially, you take the anterior tibial tendon, split it in two, and you attach one on each side of the foot. So that way, when they activate it, their foot goes symmetrically up and it's not going into equinus. There's lots of other possible treatments for spasticity, including extracorporeal shockwave therapy. Research on this is limited, but it may improve symptoms for up to 3 months. You can do a neurotomy of the T1 spinal nerve for hand flexion spasticity. Yang et al. Conducted a retrospective study looking at this and found that he saw 2 levels of improvement on the modified Ashworth scale without a decrease in strength when doing this for patients. Neuromuscular electrical stimulation, we talked about that earlier. Again, multiple studies show that it can improve function, but it doesn't exactly improve spasticity itself. This is something that I just learned about during this, getting ready for this presentation, is human recombinant hyaluronidase. So the belief is that hyaluron builds up in stiff muscles that are not moving, especially immobilized muscles. And so you can use this hyaluronidase to break up that hyaluron, which may improve range of motion in that joint again. Other things that I have looked up and saw are mostly studied in the stroke populations. This includes brain-computer interfaces, transcranial magnetic stimulation, peripheral intermittent theta burst stimulation, and deep brain stimulation. So in conclusion, spasticity is a velocity-dependent increase in muscle tone. It is commonly seen in people with cerebral palsy, as well as those status post strokes, brain injuries, spinal cord injuries, neoplasms, and multiple sclerosis. To evaluate spasticity, you do range of motion of the joint at a fast pace, and you look for a catch and release or increase in muscle tone and resistance. When starting treatment, you pretty much want to start range of motion and stretching from the get-go after an injury, especially any of the injuries that's listed above. And then you proceed to more advanced treatments, including medications and or injections if the spasticity interferes with function, hygiene, nursing care, and or causes pain. That's my presentation. I'll go back to the first slide for the CME, I guess. Any questions? Yes.
There's those devices that, like if they're walking and stuff, they go off to, you said to, like muscles and stuff, so they can, what can come up properly, whatever.
Yeah.
How does that know when to like activate? Do they have to activate it or?
Yeah, good question. So one of the devices out of the 2 that I'm familiar with has a signal in the heel. And so when the heel lifts off the ground, it causes dorsiflexion and it fires them. I think the other device is similar, and it might have like a gyroscope in it too that also can tell what angle their leg is in. Any other questions? A couple other things I'll add. When I am doing botulinum toxin injections for somebody, I see them, evaluate them, determine what dose to use, and then I do the injections and follow-up visit, and then I usually have them come back in like 4 to 6 weeks so I can see them at that peak amount of botulinum toxin working and peak effects, and that way I can decide next time I do the botulinum toxin injections, do I need to go up on the dose? Do I need to give more medication to one muscle or another? And so we do follow-ups usually 4 to 6 weeks, and then after they get on a stable regimen, it's usually every 3 months. As far as doing these procedures, Dr. Ng and I both are capable of doing these procedures and treating spasticity with oral medications, including, and then as well as the botulinum toxin injections. Again, we both trained in Milwaukee at Medical College of Wisconsin with John McGuire, who's at Guru in spasticity. So We both have better than average skill sets in this range, in this realm. And I think it's something that's not really utilized in our area as much as it could be. A lot of patients I see are going down to Freighter down in Milwaukee or over to Madison to get these injections or spasticity treatment because they don't know it's available locally. Sounds good. All right. Thank you.
Thanks.